to my wonderful positive wife, to Pamela, also widowed. We took a decision, deliberate decision, to delay having children for 7 years of love. I call it patient love. I call it considerate love, where you take a deliberate decision that no person should pick my virus from me. And indeed, one of the things I am glad to share in this conference, in this meeting, 17th meeting, is that no person in the world has my virus. In the 33 years I have lived with HIV, simply because I've taken the science of HIV, I've listened, I have put these experiences into practice, and also surrounded by love, the family, the community, and the government have helped me to adhere to treatment and to other science means of preventing HIV. The third phase is when I'm positive, I am remarried, and I have negative children, thanks to PEPFAR and to the research that helped us produce children that are negative. We have 2 children now through that program. The youngest now through that program has just joined the university, while the other one is finishing. And that's an example of the impact of science and research and community collaboration. I'm glad JCRC talks a lot about linking the 2 areas of community and science together. When you add that to good governance, like now we are talking about integration of health services to ensure that no one is missed and none of their issues is missed. So we find that we are fighting AIDS better. The 5th stage is when I am positive, but viral load undetectable. And then I have the children, they have grown, but now I have to face the non-communicable diseases, the comorbidities. So I am a cancer survivor. I had surgery, my first surgery in 2015, because of colorectal cancer stage 3. And I'm also having other issues associated with my urology issues. But in summary, I can say that those 5 stages of life have been facilitated by love, that I have been surrounded by love in all quarters to help me face the 4 types of stigma that people like me face. Stigma number 1, people fearing that you're going to die quickly, and therefore the things that we have supposed to get are withdrawn. Like, for example, I was supposed to have done a PhD in theology in 1992, but the funders said, oh, he's now positive, he won't survive. He won't survive the rigors of the PhD. So they withdrew the scholarship. Although I even heard that the other debate in the room was, is he Christian enough to deserve our funding since he's positive? Because being positive associated with sexual immorality and so forth. So the first stigma is of people thinking you are dying early. The second one is for people to think you are going to infect them. And that can even be secondary. Even the family members who are not positive begin getting stigmatized because they are coming from a positive father or a positive mother. People tend to assume unnecessarily that the children are also positive. The third stigma is where they associate your infection with immorality, as I have already explained, and that is made worse by the popular message we had to fight AIDS, the ABC message. It's a good message from the prevention side, but from us who are living with HIV, people, when you say I'm positive, they say, okay, stop there. So you couldn't have to stay, you are not faithful, and you are even so stupid, you couldn't even use condoms. So, but I noticed that type of stigma a lot when I deliberately chose to prevent mother-to-child transmission and also reinfections in my wife, and adopted correct and consistent condom use in my marriage. But when you go to the pharmacy, then the girl looks at you and say, wait a minute, you are a reverend? I said, yes. Did you ask for condoms or Colgate? The girl wants to say, oh, yeah, I talked about Colgate, but you know what you want. But she's like, hey, Sina has gone too far. Even the reverends are asking for condoms. So you begin lecturing in the house, in the room, in the pharmacy to say, look, I'm not going to fornicate. I am not going to commit adultery. My wife and I are positive, so we guard against reinfection, but also guarding against producing children that could be positive. And the girl understands, but you notice that type of stigma that stigmatizes both the disease, the person with it, and the gadgets available, the scientific products that are there. And I hear it's the same stigma that people using lubricants, face, and others. So that's my experience. What have I learned from all that? And what am I telling the conference? That I am alive 33 years later because love worked in my life. Love from God. When people are saying it is a curse from God, me, I was looking in the face of God and I was hearing him say, you are my beloved child. I was affirmed in front of my Creator. Love from family and friends. People from my late wife, up to now, they are very, very supportive. My current wife, the family there is very supportive, and the friends, as you have heard, we have a full organization of Friends of Canon Gideon Foundation. Friends coming together to pray and to help me live this far. Then I love from the community, communities of worship, communities of where I work, communities where I serve and live. You know, when you live there without being stigmatized, without being discriminated against, without being excluded from the services, it adds on you living longer. Then love from the health service providers, and I'm glad I'm surrounded with the doctors in the room, you know, because when I look back, I would say, where would I be without doctors? Nursing from 1998 when I was dying with advanced AIDS and had all symptoms except meningitis, but the doctors took me on, the nurses cared, people volunteered to, even when I have these complications of surgeries and post-surgeries, still you see the health providers very, very committed to give me a quality life. And finally, love from government. It's not a coincidence that when I was dying in 98, His Excellency the President was starting JSCRC and Mount May, these specialized centers that have really given us good life and a lease of life, which means that love from government, intergovernment organizations, and from the global community. When you combine it with love at family level, at community level, and from the service providers, you get very good results. So what's my call of action? Since love is very simple, and I've seen it in my life and many others, why don't we integrate it in health service delivery? Why don't we measure it so that we can, know? Because where there is love, there is no stigma, there is no discrimination, there is no prejudice. People take their ARVs well. Right now, Minister of Health recently published saying that we have 200,000 people who are positive but are lost to care. And when you look at that map, you find that those people are not very far away from the well-served centers, Masaka, Mbarara, Kampala. That means the services are there, but they are not accessing because of lack of love. They feel stigmatized, ashamed, abandoned, excluded. And The Minister of Health also told us that there are 80,000 Ugandans who are struggling in care. The medicines are there, but they can't because of lack of love when they need it most to survive, to thrive, like Gideon has done. So I call upon the scientific community to work with the spiritual community and the faith communities to help us. That commodity that aids, that love is not just a spiritual virtue or a moral value or a civic norm just to be happy with. We should also know it is a community leadership strategy. It is a science. It's a societal governance frame. It's also a health integration tool to make sure that we defeat stigma and prejudice, and to make sure that no one is left behind or worse, outside the care that is available, being provided for by Uganda government and other governments in the world, especially in the 20 most burdened AIDS countries in the world that are contributing the biggest challenge to ending AIDS faster, smarter, and better. Thank you very much. Remain blessed and a blessed God.
Thank you very much, Reverend Yambisha, for that inspiring talk, for preaching love to us. Yes, the Ministry of Health is here. We are here as implementing partners, and we've taken the call to action. I think for a while, the faith-based organizations have been integrated into the HIV care, but as we go into full integration, that is an area for strengthening. Okay, I'll now introduce our next speaker, Dr. Adoke Yeka. I hope I pronounced that well. He's a lecturer at Makerere University School of Public Health and a director and principal investigator at the Infectious Diseases Research Collaboration, IDRC. He has a research interest in infectious disease control and maternal and child health. He's a distinguished public health researcher and medical doctor with over 2 decades of experience in infectious disease control, particularly malaria, tuberculosis, and HIV. His work encompassed anti-malarial drug efficacy trials, malaria vaccine evaluations, surveillance of intervention impact, and operational research to inform such strategies as indoor residual spraying, long-lasting insecticide nets, and test, treat, track policies. He's an accomplished malaria epidemiologist and educator with proven leadership in infectious disease research, program implementation, and capacity development. His work continues to shape malaria control and elimination strategies in Uganda and the broader African region. His works have been supported by partners like Global Fund, USAID, Sanofi Ventis, Rotary International, Gates Foundation, and the University of Oxford. You're welcome, Dr.
Thank you very much. Thank you, Chair, for the introduction. I'm just going to give a brief talk, giving my perspective about malaria treatment efficacy and the recently introduced malaria vaccination in Uganda. Just to tell you something briefly about the malaria burden in Uganda. Uganda is one of the countries that has a very high burden of malaria, high mortality, and it records about 12 to 16 million cases annually. In 2024, had about 10.9 million cases. And also a lot of deaths, ranging from around 2,000 to 15,000 deaths annually. Of course, this varies with the different data sources. And if you look at the burden of cases in health facilities, it's responsible for quite a big proportion of cases, up to around 40%, up to about 25% of admissions, and 14% of inpatient deaths. Our talk is going to focus more on treatment and the vaccination. So what is the current treatment policy in Uganda? As per WHO recommendations, uncomplicated malaria is treated with the ACTs. In our first line therapies are mifantrin, artesunate amodiaquine, and pyronide inattesuate, which is mainly used in the private sector. Second line treatment is didatomycin piperacin, the oral quinine. For complicated malaria, the recommended first line drug is that intravenous artesunate, or in absence of that, we use the second line drug, which is intravenous quinine. There are also recommendations for prevention of malaria for IPTP, we still use SP. And for seasonal malaria prevention, a combination of sulfadoxypyrimethamine and amoxicillin. Malaria vaccinations, something recently introduced. Here in Uganda, they have recommended the use of R21 matrix vaccine that has been introduced with the routine immunization schedule. The rollout began this year around April, and this targeted children in 105 high and moderate transmission districts. Of course, this vaccine is given in 4-dose schedule, 6 months, 7, 8 months, and then the fourth at 18 months. So it is just being given as a complementary tool to other existing malaria prevention measures. Now, moving to the treatment efficacy itself. People have been talking about no response to current antimalarial drugs when used to treat people. So we have scientifically measured this to see the efficacy of the current drugs for treatment of malaria. So there are 3 methods used using therapeutic efficacy trials: ex vivo methods and molecular surveillance. And I'm going to present results mainly from therapeutic efficacy and molecular surveillance. So we have been doing studies in Uganda over a number of years. The data I'm going to present comes over a number of years. And usually for children aged about 6 months to 10 years, those with history of fever or confirmed fever in the past 24 hours. Those who have plasmodium falciparum monoinfection, parastemia ranging from 2,000 to 200,000, and those severe disease. So focusing on those with uncomplicated malaria. And the outcomes are classified according to the WHO guidelines as early treatment failure. That's when you fail between the day you present, what you call day 0, and day 3. Late clinical failure. That's when you fail after day 3, from day 4 up to the last day of follow-up with symptoms of malaria. Then you have late pathological failure. If there is presence of parasites during follow-up from day 7 up to the last day of follow-up without symptoms of malaria, then the last outcome is adequate clinical and parasitological response. That's when you do not meet any of the first 3 criteria, not meet criteria of early treatment failure, late clinical failure, or late parasitological failure at the end of the follow-up. Since we can have recurrent infections, which may be new, or persistence of the previous infection, which is recrudescence, so we use genotyping to distinguish recrudescence from new infections. How is the study conducted? We use the WHO guidelines. Drugs are dosed according to WHO weight-based guidelines. Mifantrin given twice a day over 3 days. Didatomycin piperacin given once a day over 3 days. Artesunate amodiaquine again given once a day over 3 days. The same for paranoid attachment. But in all the studies, treatment is directly observed patients for about 30 minutes to see if there's any vomiting. If there's vomiting, the medication is re-administered. And these studies have been conducted across Uganda over many years. Let's go and see the results. So we begin with the first drug, artesunate amodiaquine. Looking at its efficacy over the years from 2011 to 2020. And the recommended efficacy is 90%. Anything below 90% needs change of treatment policy. So studies were done in Apache, Mubende, Kanungu around 2013, and in Mubende, Kanungu around 2019. So if you look at average efficacy, which is uncorrected, and when you talk of efficacy uncorrected, the proportion who responded well to treatment before genotyping was done. It was around 84%. It ranged from 62 to 98%. If we take the example of Mubende in 2013, look at Mubende in 2013, the efficacy uncorrected is closer to 70%. So it means 30% presented with the recurrent malaria. And in clinical settings, those 30% need retreatment. So you look at it in this way. Those who do not meet the uncorrected efficacy need retreatment. So in places like Mubende and Kanungu, close to 30 to 40% of patients needed treatment. And if you look at all sites close to about 50% of patients needed treatment during the days of follow-up. But after correcting the genotyping, where we distinguish between rudescence and the new infections, the drug was 100% effective. For artemether lumefantrine, in 2011, 2020, studies were done across many sites in Arua, Mbale, Gulu, in 2016, and again in Arua, Apache, and Busia in 2019. The uncorrected efficacy was low, on average at about 55%, ranging from 31 to 71%. So if you look at a place like Gulu, efficacy was about 31% uncorrected. It means 70% of patients needed treatment within 28 days of follow-up. Of course, that has got public health implications, but after correcting with the genotyping, the average efficacy was 94%, but ranging from 87 to 100. Now, if you look at 87, it means efficacy has dropped below 90 in some areas. Narua was already below 90, and in Busia, it was below 90. And yes, WHO recommendation is once efficacy is below 10%, you change the treatment route. Move to the next. Looking at dimethyl piperacin. Since piperacin is longer, I think the follow-up is longer, of the 2 days. Between 2011 to 2020, studies were conducted in Arua, Mbale, Gulu in 2016. Again in Arua, Apache, and Busia in 2019. Average efficacy uncorrected is 77%, again ranging from 62 to 87%. But after correction, efficacy was fairly high, 96%. So ranging from 90 to 98. So for dimethyl piperacin, efficacy was above 90%, the corrected one at all sites. The next. Now, this is the most recent study. The most recent study was done between 2022 2023, and we looked at the 4 drugs, artemether lumefantrine, pyronide attachment, amodiaquine, and dimethyl piperacin. Studies were conducted at Arua, Busia, and Agago districts. There are important things to notice. Treatment uncorrected. Treatment efficacy uncorrected was low in Arua and Busia. So a high proportion needed to be treated. But even after correction, the efficacy of antiretroviral infantry in Arua following correction was low. Even at Busia was below 90%, and it increased. So performance of antiretroviral infantry has been getting worse over the years. But 2023, efficacy in Arua and in Busia was below 90%. In Arua, again, pyronidine attachment, we see it is borderline, close to 90%. Meanwhile, in Adago, the corrective efficacy was good. Let's move. Next. So, what does this tell us? It tells us that resistance to the ACTs is emerging in some parts of Uganda. And if you look at this, artemisinin pastoral resistance is a growing threat worldwide. Suspected pastoral resistance has been there in some countries in Africa, the countries shown in blue, and the ones shown in green have confirmed pastoral resistance to artemisinin. And Uganda is one of those countries, in Uganda, in Rwanda, in Tanzania, and in Eritrea. We use the K13 mutations as a marker for artemisinin resistance. And if you look at these maps of Uganda for the various phenotypes, the proportion of mutant parasites is variable and it is quite high. Those parts in dark that you see in northern Uganda, parts of eastern Uganda, we see very high prevalence of K13 mutations in Uganda according to the 2024 data. How about for markers which are associated with the aminoquinoline resistance? We also see very high prevalence for PFCRT markers, particularly in the West Nile region. To tell you about the treatment policy, I've kept on this. What actions are you supposed to take following such results? We normally look at day 3 parastemia when we are following patients, and also outcomes during either day 28 or day 48 of follow-up. So by day 3, if the proportion of patients with the parastemia is over 10%, is an indication to change treatment policy. And if again by day 28 or 48, you have proportion of treatment failure is above 10%, is again another indication to change treatment policy. I'm not going to details of all that in the interest of time. So, what is the summary of our key findings about efficacy? We see that efficacy of artemisinin has been gradually reducing or waning over time, and the recent efficacy of artemisinin was below WHO threshold of 90% in Arua and in Busia. However, the efficacy of diartemisinin, piperacin, artesunate, and mondiaquine was above 90% at all sites, and you see high prevalence of molecular markers for aminoquinoline resistance. Also the same prevalence of K13 mutations. Next. So what is the policy implication for that? Now we have established the resistance in some parts of the country. And in other parts, the current recommended drugs work. So the country needs to take measures to counteract the emergence of resistance to the ACT partners. And there are many measures that the country can take. Change of policy is one of measures among many other measures. So it's important to continue team surveillance of the efficacy of the drugs. And if you are thinking of deploying multiple first-line treatments, we need to take into consideration the distribution of molecular markers across these regions. Now, briefly about malaria vaccines. Briefly about the malaria vaccines. Of course, as I mentioned earlier, Uganda has launched the rollout of malaria vaccines, planning to distribute about 2.3 million doses to about 1.1 million children across 105 districts. Of course, they're using the R21 vaccine, which has shown efficacy of about 77% in phase 23 trials, performing better than the RTSS vaccine. Of course, real world studies which are done later on countries like Ghana, Kenya, and Malawi, they recorded 13% reductions in all-cause child mortality when the vaccines were introduced. And the experts project that use of the vaccines can prevent about 800 severe malaria cases per day. So, if the vaccines are used, it means fewer clinic visits, lower treatment costs, improved child survival, and stronger community productivity. Of course, as mentioned earlier, the vaccine is a complementary tool. Modeling studies done at the sort that combining the vaccine with other controlled interventions can lead to a drop in malaria burden by 73%. So, will the vaccine be a game changer or not? To some extent. However, there are challenges. The vaccine needs to be used together with traditional tools. Of course, the modeling shows that use of the vaccine can lead to impact if combined with other tools. And for us to get the full protection, the children need to get all the 4 doses, which is challenging. Something which is quite challenging. The other issues related to financing. The current rollout is backed by funding of government. What about the long-term funding beyond 2026? Continued surveillance is needed, and overall, vaccine success depends on maintaining other control interventions. So, will it be a game changer in Uganda or not? You have seen that Uganda is using a highly effective vaccine, which is protecting most vulnerable children in Uganda. So Uganda has planned a huge rollout. There's very strong planning. So we hope it will be significant to reduce severe malaria deaths and to reduce the strain in the healthcare system. However, that will depend on high coverage. It will depend on integration of existing interventions and long-term funding commitments. If this can be sustained, we can expect a change in malaria dynamics in moving the country closer to a malaria resilient future. Thank you. That's the end of my presentation.
Thank you very much, Dr. Doke, for that insightful presentation on anti-malaria resistance and the vaccine, the update on the vaccine. We'll have questions at the end of the session after all the presenters have presented. Next in line, we have our host, Dr. Sisi Chicho, and she's going to give us a session on injectable art. Dr. Sisi is the Executive Director of the Joint Clinical Research Center and the Director for the JCRC College of American Pathologists, the CAP certified laboratories. She's an experienced medical doctor, vaccinologist, and public health expert with over 27 years experience in conducting and coordinating AIDS research and care for patients. She's one of the pioneers in the prescribing art in sub-Saharan Africa. She has been at the forefront of scaling up HIV treatment in Uganda, including extension of antiretroviral therapy to all districts in Uganda. She spearheaded the development of the state-of-the-art CAF-accredited clinical and Research Laboratory at JCRC, equipped to perform a variety of tests and research studies, including molecular biology, HIV resistance, tuberculosis, HIV vaccine trials, pharmacokinetic studies, among others. She has been the principal investigator and co-investigator for operational, clinical, and epidemiological trials of HIV treatment and associated infections, including TB, as well as intervention studies aimed at preventing HIV transmission and preparation for HIV vaccines. She's a site PI for the Gilead Sciences studies and co-PI for the JCRC Clinical Research Sites, CRS, of the AIDS Clinical Trials Group Network. She's a founder member of the Global Gene Therapy Initiative, which was formed to tackle the barriers to developing countries' inclusion in gene therapy development, and is working with various stakeholders to identify and address key areas that are requisite to successful implementation of gene therapy in developing countries. Welcome, Dr. Chicho.
So thank you, Chair, for the introduction. I will briefly, in 15 minutes, go over this presentation because the next presentation, I think, will speak more about long-acting antiviral therapy. Yes. Okay. So very briefly, I'll talk about the progress towards the HIV epidemic control. As of December last year, we have done a lot of work collectively across the world. 77% of people living with HIV globally are now on ART. 91% of these, which is 28.8 million, are residing in low and middle income countries, and 75% of these are in sub-Saharan Africa. So of all these people on ART, and not biologically suppressed, because although we are using TLD, it is a very good drug, there are still patients who are not suppressed. 89% of those who are not suppressed live in low and middle income countries, and more than half of these are from sub-Saharan Africa. So this is the HIV treatment landscape, but I think most of us know really what is happening. Daily ART requires strict adherence, but there are many barriers, and many people are not always adherent to their drug. And this inconsistent non-adherence can cause treatment failure, increased viral load, increased drug resistance, higher risk of HIV transmission, and higher morbidity. And we also have specific vulnerable populations, including adolescents, mobile populations, and those with mental health. So moving forward, I think we need innovative solutions to help maintain adherence and achieve long-term treatment success, and also health outcomes. HIV treatment has evolved to address the needs of people living with HIV beyond viral suppression. Initially, we had many pills, and the main thing we looked at, are you biologically suppressed? We have moved on, and success has become prolonging life with fewer short and long-term side effects, and also more convenient dosing. And now we have 3 drugs in 1 pill. TLD is an example, but again, we are moving on. The era now is even in 1 pill now, including studies that we have done here at the JCRC. We have 1 pill with 2 drugs that is working very well. And I think it's already now in the WHO guidelines. But very excitingly, we have also 2 drugs that can be given as injections at least every 2 months for now. But I think the field is also evolving. Next. So besides the targets that have been set for us by UNAIDS, we now are talking of the 4th 90 or 4th 95. We want to ensure long-term well-being of people living with HIV. And one of these, we are looking at high quality of life, decreasing stigma and discrimination, and helping to address key unmet needs of people living with HIV, but also on treatment. So it's not just treatment, it is beyond treatment. Now we need to look at the quality of life of patients. Next. So long-acting antiretroviral therapy, which reduces dosing frequency, can ease the burden of daily pills. It can improve adherence and treatment outcomes for those challenged by daily oral regimens. And the formulation maintains therapeutic drug levels over extended periods of time. That's why it's long-acting. And this enhances effective HIV management. So long-acting ART, which I will call LA, has the potential to enhance ART delivery and support achieving widespread virus suppression targets, particularly in low and middle income countries. And achieving viral suppression, of course, will help us again reach the global target of ending AIDS as a public health threat, because high viral loads continue to provide the route for transmission, getting new infections. But as I already said, it also causes increased morbidity and also the development of HIV drug resistance. So these are studies that have been conducted in high-income countries and have led to the registration of long-acting ART using 2 drugs. This is cabotegravir and rilpivirine. And these were registration trials, and they did establish that long-acting therapy is not inferior, or it is equivalent to taking oral ART, a pill every day. But this cabotegravir and rilpivirine combination is taken every 2 months. Next. So now there are guidelines in Europe, in US, that recommend the use of cabotegravir and rilpivirine. At least was 2020 for people who are already biologically suppressed. And so the rollout of long-acting ART is happening. But I've had also many people call me from here, can we come for long ART? Not yet. Next. So all the pooled data from these registration trials showed that long-acting ART given every 2 months was preferred to taking daily pills. And as you can see, 98% of the participants who were asked preferred to go on long-acting ART. Next slide. So from the clinical trials, of course, now there are implementation projects, because there is rollout in the West of cabotegravir and rilpivirine. And even in the implementation trials, there are several of these. Over 90% of people prefer cabotegravir and rilpivirine. There is convenience. They don't have to worry about taking pills every day. But there is also pill fatigue. There are many people. There are people I've treated from over 20 years. They are very adherent to their treatment. Some of them are not, but some are very adherent. But people get tired, like many of you who are here who cannot finish a dose of malaria, and that's why we are getting resistant. So people also do not want to be carrying around their drugs. You have to shift here, you forget sometimes. And then when you're not taking your pills every day, then you do not have to think about your HIV status every day. Every day is a reminder as you take your pill. Next. But also now long-acting ART has demonstrated efficacy in patients who had a high viral load. This same combination of cabotegravir and bupropion. And on the right are just some of the few studies. As you can see, the numbers are few, but this is what it has demonstrated. Next slide. So based on these few studies, the IAS guidelines were modified in March 2024 to include also use of cabotegravir and bupropion in patients who are not virologically suppressed. So if you're suppressed, you can switch, but also if you're not suppressed, now the guidelines allow that you can switch to this long-acting ART. Next. So how do we get long-acting ART into Africa? So what is good for the high-income countries is good for us. So we have to chase and make sure that we also have these drugs here. Next. So at the time, we're thinking about trials that are relevant for our populations. There was a question, should we just adopt what has been done in the West so that we can apply it here? And you know that for us to have these drugs even in WHO guidelines, we have to provide the evidence. So there was a big gap. In sub-Saharan Africa, we are mainly following a public health approach for treatment, and this is not the same in high-income countries. So there was a knowledge gap which we had to fill. Next. So we did design the CARES, is an abbreviation of cabotegravir and bupropion efficacy and safety trial. We designed it to provide additional evidence required to determine the role of long-acting ART in Africa, where most of the population affected is Black African women. They have different HIV subtypes. We have very high levels of NNRTI resistance, exposure, and pretreatment resistance. And that's why we switched to TLD. And yet one of the drugs in this combination is in the class of NNRTIs. So care and treatment strategies are different with infrequent viral load and safety monitoring. So we have already previously reported the non-inferior efficacy of long-acting versus oral ART taken every day at week 48. We already published that in Lancet. So we needed longer-term data to assess the durability in program settings. So we've also already completed follow-up for week 96, and that paper is out in Nature Medicine last week. So I think we will send out a link to all of you so that you can read at least publications coming out of Africa. Next. I'll not go into the details of this, but this was a phase 3 randomized open-label active control multi-center trial, which recruited patients who were adherent and biologically suppressed. We randomized them to stay on their oral therapy, which included tenofovir 3TC, with either dolutegravir, nevirapine, or efavirenz, or we randomized them to take cabotegravir and bupropion injections every 2 months. We followed them up for week 48, and we also completed week 96. Next. We had a total of, we recruited participants from 8 sites in Uganda, Kenya, and South Africa. And JCRC was the coordinator for this study. But we also, at week 96, we had very high retention, which was 99%. Next. So very briefly, these were the results. As you can see in that red bar, that is the viral load suppression after week 96. And you can see that there was no difference between those ones who stayed on oral therapy and those who switched to long-acting ART. Next slide. And again, no. Back. So on the right, that is just to demonstrate that there was non-inferiority between the two arms. Yes. So we also asked about treatment satisfaction and preference in cares at week 96. And as you can see, over 99% of the participants on long-acting preferred long-acting therapy over daily oral treatment, which they were taking before we switched and randomized them to this. So these are very similar results to what we saw in the West. And now the CARES is contributing data to world data. You see all the other studies were done in the West except CARES, which we now have for 2 years follow-up. But you can see also have studies that have followed up participants 5 years and still counting. So the efficacy of these long-acting ART is really very good. Yes. But we also have other work that is ongoing in sub-Saharan Africa. And this is what the abbreviation is called the Impala study. And this is coordinated, it's led by the MRC UBRI. The name is very long, and London School or whatever. Yeah, so Fiona is the PI for that. Next. So basically, just at the bottom, I just want to show we did the CARES in patients who were adherent and virologically suppressed. The Impala is a follow-on study. No? The Impala is a follow-on study in adults who had had problems with adherence in the past, but at the time of recruitment in this study, they were also virologically suppressed. Next. So this slide is really to demonstrate that we got similar results in this Impala study at week 48. And this data was presented at the IAS in Kigali in July. So it still showed that even with these people who had in the past had biologic blips or biologic non-suppression, these participants long-acting ART was non-inferior to oral ART. Next, yeah, there. So they also looked at treatment preference, and again, you can see that a very big percentage preferred long-acting. Next. We are also part of another trial in adolescents. You know, this is the vulnerable group where there is a lot of non-adherence, and this trial recruited children from 12 to 19 years. Next. The study is coordinated by Baylor, and the sponsor is the MRC, but this is funding from EU. And again, the follow-up is ongoing, and the study is going on very well. And we expect to have report of these results at IAS in 2026. Next. So, with the results from CARES, we have impacted policy at WHO. In Kigali, the WHO updated the policy, and now long-acting injectable cabotegravir and rilpivirine can be used as an alternative switching option in adults. And they've added adolescents, although the latter results are yet to come out. But so this is very exciting. We have trial data in our context that has led to guideline change. But our happiness was not long-lived, because this combination may not be available to us in sub-Saharan Africa. J&J, which funded this study, has withdrawn or is not pursuing patents in 90 low and middle income countries. to allow generic manufacturers to develop their own versions. So we have a combination that we can use. We have very clear data, but we do not have access to reprieve. Actually to both, because cabotegravir, which is developed by VIV is only responsible for the high income countries. Janssen was responsible for us, that's why they funded this study. But along the way, policies changed. And so this is where we are today. This is now relating to generics. VIV has updated the voluntary licenses of cabotegravir long-acting from PrEP only to also treatment. And we hope that the generic manufacturers who are producing cabotegravir will also produce reprieve, but there are no guarantees. Next. So we are sort of left in a vacuum. And for those people, the patients who are calling me, I cannot offer cabotegravir and reprieve because they are not available. So we are thinking, what next? And the next available combination for on drugs available on the market is cabotegravir, which is given every 2 months, and then lenacapavir, which is given every 6 months. And as a country, we are going to roll out lenacapavir for PrEP, starting maybe about February next year. Next. So I've already talked, this is the potential combination, and now we are working on clinical trials. Next. But this combination now has also been evaluated in patients. This is a case series, and these are few patients in the US for patients who are not biologically suppressed. Next. So within the ACTG is funded by NIH as a network, and we are part of the ACTG as a site. So we are already working on a protocol which should be ready towards the end of January to evaluate lenacapavir given every 6 months and cabotegravir given every 2 months. Next. This really is to demonstrate that the efforts to get cabotegravir and lenacapavir produced as generics, and we've also been able to roll out treatment for HIV because we had generics. And for these drugs, they will be, I think, available in the market towards the end of next year, but there are also registration issues, and maybe January or February 2027, that's when these drugs will be available, but we will also be a long way in our study. Next. A cost effectiveness study has been done on using long-acting lenacapavir and cabotegravir, and I will not go into the details. Next. But it has this cost effectiveness. This is modeling, by the way. It has shown that there is reduction in HIV-related deaths. There is improved adherence and viral suppression, and then there is also decrease in the mother-to-child transmission. So this is already data that is supporting the work that we hope to show evidence from a clinical trial. So as we think about long-acting ART, there are also barriers to implementation. The barriers are not limited to low and middle income countries. So I think as we prepare also for the lenacapavir rollout for PrEP, we should be working as countries to address the barriers that may come with rolling out long-acting therapy. Next. I think these are health system challenges, implementation challenges, individual level challenges. So it's not like we have a one project that's going to solve it all. Even long-acting will have its own challenges, which we need to sort out. And then next. Looking at where are we going in the future? But maybe the next presenter will talk about this, but there are many drugs in the pipeline. Some are oral, take once a week, take once a month. Then injectables, cabotegravir and reprieve is being evaluated to be taken every 4 months. instead of every 2 months. That again is happening in Europe. And cabotegravir, already there is data to show that it can extend for 1 year. So you imagine having your treatment once a year, but there is no companion drug. It can do very well now for PrEP, but there is no companion drug. And also many groups are looking at how we can deliver the long injectable drugs instead of an injection, we do an implant. And so with those few overviews, I would like to acknowledge, of course, the research scientists, clinicians, who have contributed clinical trial and real world evidence. Real world evidence. I know there is someone in this room who is so interested in real world evidence for use of long-acting ART. We, of course, thank the trial participants and then the implementers who take up WHO recommendations and deliver long-acting ART to those who need it most. Thank you very much.
Thank you, Dr. Chicho, for that insightful presentation, for giving us the updates on long-acting ART in future direction. We pray we can both get some of those into Africa very soon. And thank you for ushering us into the next session on optimizing HIV management with long-acting and once-daily ART. And that is going to be presented by Dr. Richard Illion, who has been active in HIV care and research for 28 years. He currently leads a team at Whitman Walker that is focusing on cutting-edge research initiatives in prevention and treatment of HIV/AIDS, hepatitis C, and other STDs. Dr. Illion's tenure at the Whitman Walker coincided with the organization being selected in 2013 as part of the AIDS Clinical Trials Group by the National Institute of Health, a distinguished honor for Whitman Walker and rare for a community health center. Prior to joining Whitman Walker Health, Dr. Illion served as the co-director of HIV services at the Washington Free Clinic in private practice in Washington, D.C., and in various research and clinical capacities in New York and in Washington. He received a bachelor's degree in English and psychobiology from the Tufts University and a medical degree from Temple University. He completed his internship and residency at Duke University. He also holds a master's degree in counseling and spiritual psychology from the University of Santa Monica. In addition to his duties at the Whitman Walker, he is currently an associate clinical professor of internal medicine at George Washington University and at Johns Hopkins University. Welcome, Dr. Illion.
Richard Illion, presenting Optimizing HIV Management with Long-Acting and Once-Daily Antiretroviral Therapy. Please sign in if you're here if you wish to get credit. Failure to provide complete information may disqualify you from participating in future activities. No fees for this process. Please refer to the activity materials emailed to you for accreditation disclosure. If you did not get any of these materials, please speak to the conference organizers and we will take care of that. You will receive an electronic initial evaluation to the email address provided within 1 to 3 business days. Please fill out these evaluations. These help us plan future programs. We're interested also, if you want to get credit, you have to fill them out. There'll be a long-term evaluation about 8 to 12 weeks afterwards to see how this information and how this education has impacted your treatment paradigms. My name is Richard Illion. I'm a clinical professor of medicine at George Washington University School of Medicine. My disclosures are listed here. Learning objectives today are to, first of all, understand key considerations associated with initiating and maintaining antiretroviral therapy in diverse and challenging populations, to look at the benefits of long-acting ART in diverse and challenging populations, and discuss the challenges that patients face when interacting with healthcare providers regarding this HIV care. The first thing we're going to deal with is HIV treatment targets and initial ART. You can see here that when we look at new diagnoses, the new diagnoses are still outpacing what we'd like. In 2025 in the United States, and I'm sure this is even similar in Uganda, we see our goal was less than 10,000 patients, but we're having over 37,000, almost 4 times as much. There are also inequities to notice, that both differences in race and ethnicity of the populations being affected, differences in geography based on healthcare access and demographics of the population, and differences in age as well as risk categories help us to see differences in these rates of transmission. Furthermore, when we look at the stages, we see that majority of people are presenting in an intermediate stage. And when we look at later stage disease, still almost 20% of the population is presenting late in the diagnosis. So this is an issue because you have extensive morbidity as well as increased rates of transmission for people who present later. So it's important to be able to move this up to earlier times. The issues about getting suppressed of people on treatment, we see about 69%, with our goal being 95%. However, of those 69% who get on, only about 2/3 of them stay suppressed. So about 65%, meaning about 1/3 of the population is still unsuppressed who are HIV positive. And so this is hardly reaching our goals. It's laudable we've made it to 2/3, but not good enough that we're only at 2/3. There are multiple reasons for this and barriers to engagement. First of all, we look at poor access being the main one. Stigma, unstable housing, low health literacy, mental health, substance use, if they've had issues with criminal activity. There are a variety of reasons. In Uganda, you also have reasons of drug access, of transportation, of things that can affect this, of stigma, not wanting to be known going to that clinic. So all of these are important issues that we look at engagement that make engagement harder. Initial ART, for the most part, if patients have not been on PrEP, would be either bictegravir, FTC, TAF, dolutegravir, TAF, or TDF and XTC, or dolutegravir and 3TC, and this is in the United States. I believe here in Uganda, the most common approach is dolutegravir, TDF, and 3TC. If people have been on PrEP, you can still start them on bictegravir, FTC, TAF, or dolutegravir and TAF and TDF, or 3TC or FTC, or you could put them on long-acting cabotegravir, or if they were on long-acting cabotegravir, you'd put them on boosted darunavir plus a combination of nukes. The things that I want to point out that have changed in the United States guidelines are, first of all, abacavir's been taken off, elvitegravir boosted with cobicistat, boosted atazanavir, efavirenz with pivirine, all taken off of these regimens. Now it's really integrase-based with a little bit of room still for proteases in patients who have been on long-acting cabotegravir. Recommended during pregnancy, dolutegravir and TAF plus XTC or TDF as well. Some of the reasons for these changes: the REPRIEVE trial looked at the cardiovascular risk hazards of various regimens. They found a significant increase when the NRTI abacavir was included. And so for this reason, abacavir had a significantly increased risk of cardiovascular events compared to other nukes, and so abacavir is no longer recommended. This data has been reported earlier. This was just a confirmation of these findings, but enough now that there's very little question about the association. Bictegravir and FTC TAF versus dolutegravir and 2 NRTIs. This is a common question, and this is a study that looked at this in patients with suboptimal adherence. This was looking at retrospective analyses, and so we looked at different studies, and adherence categories were listed as high, intermediate, or low. And the bottom line here was that you had high rates of suppression with both regimens, both bictegravir and dolutegravir. However, when you had low adherence, you didn't have lower viral rates of suppression with bictegravir, FTC, TAF, but you did have lower rates of suppression with dolutegravir. And so this suggests that bictegravir maybe has a little bit longer time it stays in the bloodstream, or there's differences in resistance in low adherent patients, but in high and intermediate adherence, there were no differences. Remember, low was taking less than 85% of the medications. That's not so different than a lot of the patients you might see, and so it's worth it to think about these differences in adherence with performance if you have a patient who fits into that category. But I want to stress, in the high and intermediate groups, there were no difference in virologic performance. The Dolce study looked at 2 versus 3 drug ART based. And so the idea here was to compare the dolutegravir 3TC with dolutegravir TDF and 3TC or FTC. And these patients were CD4 counts less than 200, so we wanted to stress the regimen to see if patients were more immunologically suppressed, how would it do when viral loads were greater than 1,000. And the results were almost exactly the same. Dolutegravir and 3TC overall, and in the baseline group greater than 10,000, there was a slight 4% difference favoring the dolutegravir 3TC group than the 3-drug regimen. Virologic non-response rates were about 12%. There were some differences in metabolic outcomes, but very, very little to talk about, and both regimens were well tolerated. So this 2-drug regimen worked very well compared to 3-drug. When we compare other 2-drug regimens, this is a study looking at the non-nucleoside doravirine plus islatravir, a nucleoside reverse transcriptase translocation inhibitor, versus bictegravir FTC-TAF. And this was looking at patients looking at 48 weeks, and the bottom line was the 2 regimens were quite similar. There was no difference being seen. The virologic failure were low in both. The CD4 count changes were similar in both. There was no problem with lymphocytes, which had been reported in the past with higher doses of islatravir, and weight gains were similar in both arms. The laptop study compared integrases versus boosted PI in patients who were treatment naive but who had advanced HIV disease. Viral loads were greater than 1,000, and they could either have had AIDS, bacterial infections with a CD4 count under 200, or CD4 counts less than 100, or under treatment for OIs. And the comparison was bictegravir FTC-TAF versus darunavir with a boosted agent cobicistat and FTC-TAF. The outcomes showed bictegravir FTC-TAF was non-inferior to boosted PI-based ART. Their virologic failure was lower in the bictegravir arm, 13% versus 24%, which was significant, but there were no between-group differences in viral safety and rebound. In general, the safety of the regimens were comparable. The BIC-DOL study looked at a different question, looked at initial ART in patients with high viremia with HIV infection, and it compared bictegravir versus dolutegravir. Treatment-naive patients, the subgroups had viral loads greater than 5.7 log and acute HIV infection, and bictegravir FTC-TAF or dolutegravir plus 2 MRTIs. So really a comparison of the integrase agent. The results at 24 weeks, both regimens were highly effective. Dolutegravir-based ART achieved slightly faster control than the bictegravir. So comforting news for one of the main regimens that are used here. Let's look now at ART switch in the setting of viral suppression. Often we want to look at regimens, how to simplify things or make things easier, or if drug supply changes. And so the question about how we do this in the setting of suppression is a critical question. The foundation here, first of all, is to understand as best as possible prior treatment history. If you know what resistance people developed in the past, their comorbid conditions, how their drug-drug interactions, the presence of HBV, because that's relevant if you keep 3TC or FTC around, or if there's any barriers to getting the new regimen. The first one I want to talk about is Pasodoble, which was a phase 4 study done in Spain, hence the name Pasodoble, with a switch to either a 2 or a 3-drug ART and virologically suppressed. So people who were suppressed were either switched to DTG 3TC or BIC FTC-TAF. The key exclusions here were they couldn't have had prior virologic failure, they couldn't have had resistance, and no exposure to dolutegravir or bictegravir HBV. And this study showed very comparable virologic outcomes with both DTG and bictegravir. There was few virologic failures, one in the bictegravir FTC TAF arm, and no emergent resistance and similar gains in CD4. Weights were similar. So this is suggesting in this situation that a 2-drug regimen might be comparable to a 3-drug regimen. The DIAD study looked at switching to a 2-drug regimen when you were on a 3-drug regimen consisting of bictegravir FTC TAF in patients who were suppressed. And here you can see switch or continue. The key outcomes here showed a 85% success rate versus 81, so comparable, non-inferiority, with the 2-drug arm compared to the 3-drug arm. Virologic failures were similar in both, and there are no significant differences in safety. So the question is, 2-drug works as well as 3-drug. There wasn't an advantage to be seen in terms of safety, but it's good to know that if you can use 2, you don't necessarily need to use 3. So it depends a little bit on what your drug supply and what drugs are available to you. The CARE study looked at the question of injectables, and many of you may be familiar with this because your own Sissy Kitio is the key investigator. The CARES trial was an important study that looked at switching to long-acting injectable cabotegravir and rilpivirine in patients who are virologically suppressed. So it's a switch study. There were patients who could have been on stable ART with dolutegravir, nevirapine, efavirenz, and either any of those, TDF and 3TC or FTC, viral load less than 50 and no history of virologic failure. And it was on every 2 months injection. And the bottom line is that people who switched did just as well as the people who stayed on oral. Virologic failures were low. There were 0 in the oral arm, 4 in the long-acting arm, 2 with resistance to rilpivirine, 3 resuppressed afterwards. Both treatments were well, but high treatment satisfaction among those who switched. People who switched to the injectable were very pleased with that outcome. Impala looked at long-acting injectable cabotegravir and rilpivirine in people with prior suboptimal HIV control. So CARES were people who were suppressed. Now we're looking at people who weren't totally suppressed. These people had viral loads greater than 1,000 in the past 2 years. They had a loss to follow-up. They were unlinked to care in the last 3 months. They had a viral load at the end of screening of less than 200, so they were suppressed at the time of entry, and they had no baseline testing. So this was a group that had shown risks and viral bursts at time, but currently were suppressed. The outcomes were similar between staying on orals or going on to injectables. Non-inferiority was seen. Both treatment arms were well tolerated, but the key issue here for this adherent risk population, if you will, was that 94% preferred cabotegravir and rilpivirine versus the oral regimen. Now, when you look at what are the factors that are associated with failure to long-acting CAB and RPV, and this was looking at 650 patients in past studies, the significant predictors were if you had resistance to rilpivirine, that was one of the biggest ones. It's so very important to understand that that's the case when you're switching to injectables. The HIV subtype A6 and A1 also had an increased risk, and if you're a large BMI greater than 30. And that may be related to the size of the needle giving the injection. Factors not predictive of viral failure were the dose regimen, sex, other NNRTI resistance mutations, not inclusive of rilpivirine, and these were the keys. Looking at some studies looking at real-world experience, this was a study I was involved with, Trio Health, compared to 2 other cohorts overall and 1 women, the opera cohort, which in the United States. You can see here that consistent findings across all these cohorts, that these people had high effectiveness regardless of comorbidities in patients who were switched who were suppressed. Virologic failure rates were low and consistent with rates of clinical trials. So a large number of patients showing consistent excellent outcomes with injected cabotegravir and rilpivirine. The next question comes up looking at, well, can you use this in patients who are viremic? And so in San Francisco, a study done between 2021 and 2024, excuse me, looked at those with or without viremia who didn't have resistance. And you can see that the differences in baseline characteristics They had more substance use, the patients who were viremic, unstable housing, low CD4 counts. But the bottom line was the viral suppression rates were similar across both groups, whether you were viremic or aviremic. So this was one of the first studies that helped us understand, you could use CAB-RPV in patients who were viremic, though it was originally approved only for patients who were virologically suppressed. Other single studies looked at this and showed that retrospective chart review in Ward 86 of 438 patients showed that about 15% of the patients discontinued, 85% stayed. The most common reasons for discontinue were injection site pain or for viremic viral failure. In a group at San Diego, you could see this group, and the main thing was, again, about 85%. Most people who switched were able to resuppress, but there was a consistent number of people who didn't prefer injections, who did switch out. The relativity study was looking at a switch to long-acting injectables, CAB and RPV, in an aging population. It looked at 3,100 individuals, and the cut was age greater than 60 or less than 60. And the bottom line was it worked very well in both groups. There were high adherence. The main reasons for switch, the patients said, were simplification, improving quality of life, and or requested. And so you can see here that it worked very well with different comorbidities. The Empower study looked at switch to oral BIC FDC TAF after being on long-acting injectables. We know that 15 to 20% of patients leave acting injectables in cohort studies, and so what happens to those who go back to orals? And the bottom line is they do very well. This looked at viral loads less than 50 for greater than 6 months on injectables. They switched and they did very well, and there were no problems, no big surprises there. This study started to look at longer acting orals. As we've switched into the realm of long-acting injectables, there's been a concern that some patients may prefer long-acting oral agents. And so this study took a look at two evolving medications. The first is islatravir, which we talked about earlier, which is a nucleoside reverse transcriptase translocation inhibitor that can be given once a week. And this was paired with lenacapavir. They were started, they were given oral lenacapavir rather than the injection, which is also used, so that you could have a once a week regimen. And this was patients who had viral loads less than 50 who were switched, CD4 counts greater than 350, no history of virologic failure. And the question was, would this oral once a week regimen work? And the bottom line was, it worked great. Open label, the viral load greater than 50 was 0. Adherence was excellent. There were no discontinuations. There was no evidence of any WBC declines, which had been seen in higher dose islatravir in the past. And so this is now being pursued as a regimen. So it's exciting to think that we would have not just injectables of 2 months, 4 months, 6 months, but we'd have an oral regimen that could be once a week as well. This was a study looking at a switch to doravirine and islatravir. This was looking at people whose viral load were less than 50, and there was 051 and 052. The 051 were people who were on 2 or 3 drug ART, 052 were those on BIC-TAF. And the bottom line here was the regimens, those who switched to doravirine and islatravir versus the oral ART in both populations did very well. So this lets us see another regimen that's not integrase-based, and it might even be useful for people who could have had integrase resistance, if that starts becoming a more common issue, of the use of a novel non-nucleoside, RTI, doravirine, and islatravir. So additional outcomes, there was no differences in CD4, virologic failures were low in both groups, and the key thing with doravirine and islatravir is to be careful for patients with HPV. There is no coverage for HPV, and so reactivation is something that's going to have to be watched carefully. One of the issues is about whether TAF or TDF are associated with weight gain. So the idea of using a regimen like doravirine islatravir, which doesn't contain either, was important. And what you can see here is that comparison of TAF to a non-TAF containing regimen, there was no differences in weight, suggesting that perhaps TAF isn't as correlated with weight gain as was previously thought. Let's look at ART switch in the setting of viral suppression, but for those who had prior treatment failure. The last studies were all about people who had no prior treatment failure. So in this study, we look at people with NRTI resistance who've been on previous regimens who switched to integrase plus 2 nukes. So the question is, does this prior history of these mutations presage failure? We know that observational studies have shown that usually it's not. And the question is, how do we monitor them? First of all, monitor them closely in the first year. Check RNA levels after the switch a little closer. But in general, these kind of mutations, M184V or NRTI mutations in the presence of integrase and 2 nukes, do not predict any subsequent failure. And it's safe to do that, and it's safe to do that usually without having resistance testing available. So let's look at some of the studies. Here's the 2SD trial, which was done in Kenya. This was patients who were on a second-line PI boosted with 2 nukes. Viral load was suppressed, no prior INSTI, and they were switched to either switching to dolutegravir and 2 nukes or continue on their PI. So you wouldn't know what the mutations might be at the time. The results showed exactly the same levels of virologic suppression. There were still 20 virologic failures in each group. There was no resistance seen in the dolutegravir arm. There were 3 of the patients in the protease arm that had NRTI and NRTI mutations. So very well tolerated and no significant difference if you continued on a boosted PI or you switched to an integrase, even knowing that there was prior mutations. Vicen is a switch to open label. You failed non-nukes, efavirenz or nevarapine, and you stratified if the viral load was less than 1,000 or greater than 1,000. And there were 2 different arms. We're going to look at this study 2 different ways. The first one is going to be comparing dolutegravir plus 2 nukes versus dolutegravir plus 2 nukes but TAF. So TDF versus TAF is the main difference here. And the bottom line is they were quite similar. Virologic rebound was small, similar CD4 gains. So switching patients onto this regimen with dolutegravir worked well after failing a non-nuke. Artistry looked at a different question because it wanted to look at adding lenacapavir, which is usually used as a long-acting injectable, but now as an oral agent in the setting of bictegravir, to add increasing amounts of new targets in an oral regimen. And so this is a novel use of lenacapavir, and they tested it in 2 different doses. So the patients who came in here were virologically suppressed on whatever their background regimen had been, and they had no prior bictegravir resistance and no lenacapavir exposure. And the study showed that in the 2 groups of Len 25 and 50, the results were quite similar, 92 and 90, and the people who stayed on their background regimen continued to stay suppressed. It was well done safety, and so this helps us look at the combination of bictegravir and oral lenacapavir as a new target. Now, lenacapavir, usually we talk about it as a way to improve adherence by doing different kind of dosing, either once a week oral or every 6 months and potentially every 12 months for PrEP or for treatment. In this setting, however, it's used as a new target, just as a once-a-day regimen along with bictegravir, and was well tolerated and did very well in helping to keep these people who had multiple mutations in the past suppressed. So now let's look at the studies around virologic failure, what to do when we see people failing. When we think about patients who fail, there are a number of reasons. The first are patient-related. They didn't take their pills. There's a reason, lots of reasons they didn't take their pills. You'd have to talk to the patient about that. Is it because there were too many pills? They didn't like the way the pills made them feel. They couldn't get access to the pills. They weren't living anywhere that they could remember to take their pills and do things, other factors. So, key issue, and probably one of the main ones that makes up virologic failure. The second is virologic. Did they have resistance? Did they have too high a viral load that maybe it was hard to get that viral load down? The third is treatment related. When they're taking the drug, did they not absorb it? Is there suboptimal pharmacokinetics? Did the regimen, because of various resistance, just not work as well? Were there these regimens that had to be eaten with food and there couldn't be food that were taken? Are there drug-drug interactions that could lower the dose of the HIV medication to be used? And so you have to be cautious about that. Could they not ensure continued drug supply, a very common problem these days with relative cuts? So we know that the laboratory test, if you can, you get a viral load. If the viral load is less than 50, you're good. Wait until as long as you can before you can do another one. We're suggesting here 2 to 4 weeks. I'm sure for most people that's going to be later. If it's greater than 200, then get an NRTI PI genotype and an INSTI if the patient was on an INSTI regimen. There are other things you can do as well, but I think those are the main things you'll be looking at of laboratory tests for virologic failure here. Now the advanced study then took a look at patients who were open label, they were treatment naive, they had viral loads greater than 500, no baseline genotypes, and they could have been on dolutegravir and TAF, dolutegravir, FTC, and TDF, or efavirenz and FTC, TDF. So these were first-line dolutegravir failures, and the question is, what would be the main group? And this looked at the viral load group of who were greater than 1,000, with the idea being, how do we look at how to suppress them back after they have failed? So virologic failure rates were similar across treatment arms, however, much higher suppression rates in the dolutegravir arm compared to the efavirenz arm. And therefore, this really establishes dolutegravir as the way to go in treatment failures rather than continuing people or using a non-nuke such as efavirenz in these situations. Most individuals on continued dolutegravir after virologic failure can resuppress. So they didn't get resistance, while the people on efavirenz did. So the point being, when people fail on these two regimens, if they're on efavirenz, you're likely to have to switch. If they're in dolutegravir and you think they just weren't taking the regimen, there's a rationale to say, all right, let's really buckle down and take this regimen. Let's really see if we can do it, because there's a much higher chance of success. The Latitude study looked at the use of long-acting injectables in people who are non-adherent. This was a phase 3 study looking for over 3 years for viral loads greater than 200 of patients who have been lost to follow-up with ART non-adherence. They could have no INSTI or rilpivirine RAMs, because we know those with pre-stage failure, and they were randomized to either long-acting injectables, Q4 weeks versus standard of care. And so they were, and the results were, the key findings were the regimen failures were greater on those who stayed on oral ART. Virologic failure rates were lower throughout all the explanations in people who switched to long-acting injectables. The people who previously had been non-adherent, now 93% of them, these injections were administered on time. There were some virologic failures with new resistance mutations, and specifically E138K, which is an integrase mutation. So there is some cost to that approach, but long-acting injectables, considering all of this, was superior to continuing ART, oral ART, in this study population. Another study looking at this in Ward 86 looked at which is a clinic in San Francisco, looked at poorly adherent people who've been on, they had given CAB RPV for every 4 weeks. They couldn't have INSTI or rilpivirine mutations, and they had to have lots of ways to get in touch with the clinic. The initial cohort, they had 74% of the groups got on-time injections. 100% were suppressed at baseline. They were viremic, but 96% were viremic at baseline. So the failure rate was quite low. When we looked at the people who were viremic at baseline out at 48 weeks, 80% of them stayed on the regimen, 87% continued suppression, and a very low number had subsequent problems. So the idea of when to leverage the use of long-acting injectables in patients with viremia, we know has success. There's a lower rate of resistance. Would you want to use that compared to oral regimens? If you really had both drugs equally, certainly a conversation with the patient would merit that. If you don't, you're going to have to really buckle down on adherence, because that's probably the way this injectable works better. It levels the playing field. It makes people, it helps people to stay adherent to the regimen, which is why you get these higher rates of virologic suppression. Looking at real-world switch to long-acting CAB RPV in a study in the United States, the OPERA cohort. You can see here that in general, high persistence with moderate adherence. 60% of the people got injections on time. 85% of them had viral loads less than 50. So this was very successful in patients, again, who were viremic when they came in. Now, the viremia was rather low, less than 200, median was 120, but there was a high effect on this rate, and low virologic failure with no evidence of resistance. In other studies looking at the same approach of patients who were getting long-acting ART with viremia who had been out of care for a long time, you can see high success rates, viral load 92%, low rates of virologic failure. There are some people who develop resistance in this group, but in general, this group that wasn't coming into clinic, that was hard to get them in, are able to stay suppressed. So a very promising approach. The question's going to be, there could be a cost to doing this, both in terms of the price of medications, if that's relevant, as well as the risk of injections. But the leveraging of the adherence in these situations and the continued potency, despite perhaps prior resistance, argues that this really is a very viable option for a lot of patients, and one, if you can get access to it, makes sense to think about doing. The Nadia trial looked at the use of second-line ART after a non-nucleoside-based regimen failure, a common situation seen in Uganda for a long time. And then the question was, it was compared to use dolutegravir plus different NRTI arms versus a boosted protease with different NRTI arms. The outcomes were quite similar across the groups, with dolutegravir and darunavir being similar, non-inferiority. Rates of virologic suppression and viral rebound were similar. There were patients who did have dolutegravir resistance, but the impact of the NRTIs maintaining 3TC and tenofovir was better than switching to 3TC and zidovudine. The Vicen trial looks at second-line switch to dolutegravir and recycled NRTIs, or put patients on a PI-based ART. We looked at this study earlier. There's arm B, before we looked at arm A with dolutegravir and 3TC and TAF versus FTC and TAF. Now we're looking at it, dolutegravir with the same choices versus lopinavir and izanavir. And they were stratified by viral loads less than 1,000 or greater than 1,000. And the bottom line was, switching to dolutegravir and 3TC and TDF was non-inferior to dolutegravir, FTC, and TAF. Switching to dolutegravir-based regimens, however, was superior to switching to boosted PIs. So establishing really the role of dolutegravir being a more robust agent in these situations. The virologic rebound was low in both arms, including the PI arm, but there was less rates of suppression in the PI-based arm. The D2F study is second-line switch to dolutegravir for first-line NNRTI failure, so a common situation that you might find here. So they failed first-line NNRTIs, no prior integrase mutations, no pregnancy, and they were put either on dolutegravir and darunavir, an NRTI sparing regimen, dolutegravir and TDF in either FTC or 3TC, or they could stay on their same standard of care. The bottom line here was that the dolutegravir darunavir arm worked pretty well. The dolutegravir TDF and FTC or 3TC worked just about as well, 82% versus 86%, but the standard of care was 76%. So switching to dolutegravir ART demonstrated superiority to standard of care. There was a weight gain on these regimens versus standard of care, but however, this weight gain is really under review, and we can talk about that in Q&A, because I'm not sure that we think that the weight gain is necessarily due to the agents that are being used. But the bottom line here was that dolutegravir switches perform better than keeping people on a boosted PI. The DTG resist study wanted to look at cohorts who had integrase resistance data, almost 600 patients. About 20% were on initial regimens and about 80% were on a switch setting. And in that setting, you could see full susceptibility to dolutegravir in 94% of the patients, with about 14% being able to see integrase mutations. So about 6% of the people develop dolutegravir drug resistance. And this risk of resistance with dolutegravir was associated with, first of all, with monotherapy, with dolutegravir to the greatest degree. Second, dolutegravir 3TC dual therapy, and also with prior NRTI resistance. So monitoring is important to make sure you don't develop resistance in that setting. The Capella study sought to look at the efficacy and safety of lenacapavir when adding it to a failing regimen. So this was an idea to see how well could lenacapavir hold up in patients who were on regimens that were failing. And so this was a phase 3 treatment study where viral loads had to be greater than 400. You had to have resistance to more than 2 agents, or 3 of the 4 from 3 of the 4 main ARV classes, and you had to have less than 2 fully active agents. And you can see here that they were open label oral len just added to the regimen versus a failing regimen versus adding oral len to a failing regimen. So the difference here is that you could optimize the regimen, or you came in with what you were failing versus staying on failing without lenacapavir. And lenacapavir was added as an injection, so every 6 months. It was a useful adjunct because you didn't have to change your regimen that much. And the bottom line of the results were the on-time lenacapavir injections in general were excellent, 98%. There was a fairly high amount of people, 14%, who developed resistance to lenacapavir, and all by week 104, and all of them with no fully active drugs or non-adherence. So when you don't support lenacapavir, you're at greater risk for resistance. But lenacapavir was well tolerated, and when you looked at the viral suppression rates across the group for people who stayed on the regimen, who added len, they were quite similar between the two. The OPERA cohort looked at adherence and effectiveness of len for treatment. This is an emerging paradigm, and so they looked at patients over the last 2022 to 2024. And what they found is that INSTIs were more commonly used in prior regimens and OBR with lenacapavir. PIs and NRTIs were used less as the prior regimen. When people added len, almost 2/3 of them didn't change the regimen, and during len, 52% didn't change it. People stayed on the regimen very well, and the suppression rates were pretty good. Maintenance, people who came in suppressed 92%. Those who got to viral load were 76%. So lenacapavir as an add-on in that setting, as every 6 months, was well tolerated and pretty successful. So looking at various studies to look at lenacapavir in the setting where people are failing, you can see that close to 90% of the people stayed on. No virologic failure seen in those who were suppressed at baseline, so it could be useful to help people lower their pill burden. For those who were unsuppressed, about 82% got to suppression. And the number of active agents once you started to add lenacapavir was decreased. So this is something that I don't know that it's so available right now in Uganda, but it's something clearly that's going to help give providers different choices. And as there are other long-acting regimens that could come along to be paired with lenacapavir, the efficacy and practicality of this approach could certainly increase. So my closing remarks would be to point out that all recommended initial regimens include dolutegravir or bictegravir combined with either TAF or TDF, 3TC or FTC, or using a 2-drug regimen, DTG, 3TC. This is consistent with current practice in Uganda, where I believe you use dolutegravir, TDF, and 3TC. The foundation for successful switching is looking at all the factors that could have led into what the patient's ART history was prior, and help to pick an optimal regimen. For patients without INSTI resistance, there's a lot of choices that you could use. You can use 2-drug, you can use 3-drug. You've got a lot of choices even in patients with NRTI resistance. And recent data with use of long-acting CAB and RPV shows great benefits in viral suppression in patients with no known resistance, and even some pretty good results in patients with resistance. And so this is exciting to have these options for people who are starting to fail. These patients in the past were not patients we could successfully treat, and so we do have new options for them. I'd like to thank everybody for listening. You'll get an electronic initial evaluation in the next 1 to 3 business days. Please fill out so we can understand your appreciation or your suggestions for new programs. Thank you very much.
Presentation full of updates, and you also have session from the online team. We'll go on to our second last presentation on premium Congo hemorrhagic fever and mpox. And that is going to be presented by Dr. Frank Brown. He's online. He received a bachelor's degree in biology at the Caltech and MD at Columbia University College of Physicians and Surgeons. His postgraduate training in internal medicine and infectious diseases was at the University of Michigan and Stanford University, respectively. He was a medical epidemiologist in the hospital infection section at the Centers for Disease Control in Atlanta. And in 1979, he joined the faculty at the University of Minnesota in the Division of Infectious Diseases, Department of Medicine, where he was a toxico-epidemiologist and became associate professor. In 1987, he established the HIV clinic at the University of Minnesota, which he directed through 1995. In 1995, he moved to Northwestern Hospital, part of Alina Health, where he does infectious diseases consultation and infectious diseases research. He's now adjunct professor of infectious diseases, University of Minnesota. His research activities have involved antiretrovirals, doing pre-licensure evaluation, drugs for HIV-associated opportunistic conditions, investigator-initiated studies of the February pharmacokinetics, interleukin, two HIV vaccine trials, and two NIH-sponsored trials, seeking to mitigate HIV-associated immune activation. He was the site investigator for the CDC STAND observational study of the long-term consequences of HIV treatment. He has served on several data safety monitoring boards as a co-chair of the University of Minnesota ACT for CDC HIV-related consultation groups and on the initial NIH HIV study section. He conducted 3 hepatitis C trials, 2 influenza trials, and 2 RSV trials. He's now conducting 4 COVID-19 trials and has traveled extensively internationally to lecture. Welcome, Dr.
Thank you. Are you able to hear me all right?
Yeah.
Great. So let me share my screen and see what happens here.
Frank Rame, and I'm
No, so I'm going to share my screen. All right. Are you able to see that okay? Great. Okay. So I'm going to get my pointer out here. So can you see my pointer here? Good. All right. So good afternoon, everybody. My name is Frank Rame. I'm going to talk about Crimean Congo hemorrhagic fever, CCHF, and mpox. I don't have any disclosures. Here's our opponents, the CCHF virus, which I'm going to show here because it's got a curious 3 separate loops of single-stranded RNA that each do different things. One does the RNA-dependent RNA polymerase, one does the nucleocapsid, and one does the surface proteins. That's the virus. Mpox is a very different virus. It's a huge virus. It's a double-stranded DNA virus. It actually has codes for 191 proteins. So it does something unusual for DNA viruses. It replicates in the cytoplasm because it brings along its own machinery. So I'm going to depend on the lecture produced by this lady. She's a expert in viral hemorrhagic fevers at WHO, and it produces very nice, quite current lecture and it's so good that I'm just going to go with it with a few additions. So the burden of CCHF is substantial. It is a tick-borne disease, and it's present in Africa, the Balkans, the Middle East, and Asia. And it's unevenly distributed. You can see here that that's very high rates in some parts of the country. Uganda is intermediate in its rate. Most of the patients have subclinical disease. The global burden is between 10,000 and 15,000 CCHF infections per year, and there are about 1,000 to 2,000 deaths. The vector is even more widely distributed. There are 3 billion people at risk as a result of the vector prevalence. It's a tick, as we'll see in a second. The one slide I'm going to throw in is a slide here that looks at the question of whether or not cattle are particularly important in human disease. So these authors went to a part of Uganda that's outside of the cattle corridor, and they looked at the seroprevalence, the Masaka region. They looked at the prevalence in 3 different kinds of villages. And interestingly enough, the seroprevalence of CCHF antibody was highest in the fishing community, not higher than in the agrarian communities or the trading communities. So this suggests that it's not a simple matter of just having exposure to cattle. And their conclusion was that CCHF is widely endemic in Uganda. So here's how it spreads in a simple slide. There's a tick circulation between small mammals, birds, and the ticks. And occasionally it slops over into larger mammals. There would be the cattle. Most of the human infections come from being bitten by that tick. Some of them come from exposure to the animals that are infected. Once humans get it, there's this second set of considerations, namely, it can spread between humans, and that's the healthcare consequence that we're going to talk about at some length. The disease itself has an incubation period of up to 2 weeks. The case fatality ratio is high in patients that get hospitalized and unevenly distributed. Again, here is the distribution of the case fatality ratio for reasons I don't understand, quite a bit higher in some parts of the country than in other parts of the country. The symptoms start non-specifically with just fevers, chills, myalgias, headaches, sickness, vomiting, abdominal pain, and arthralgia. Hard to recognize at this point, but once bleeding starts, it becomes more obvious. And that bleeding can occur from mucous membranes, hematomas can develop, bruises can develop, melena, hematuria, nosebleeds, vaginal bleeding. And when things get bad, the patients have bradycardia, thrombocytopenia, and leukopenia. So here's the kind of ecchymosis one can get that makes it more clear cut. The diagnosis, again, starts because the problem starts because it's not specific. And the only way I think you can ever get it at this non-specific stage is if you pay close attention to the history and you find that the person has had exposure to ticks or wild animals or livestock in an area where there's endemicity for CCHF. Definitive diagnosis requires PCR or ELISA, and the laboratories that process these specimens have a particularly difficult burden because these specimens themselves are hazardous. Treatment is mostly supportive. So aggressive electrolyte balance, fluid balance. There is the possibility of supporting the coagulation system, namely platelet transfusions, but mostly it's just trying to take care of them. There are no approved therapeutics or vaccines. So you need to make sure that the community knows that ticks are the problem. I'm sure you are very familiar with talking to patients about ticks, so I'm not going to belabor this image or this image because I think we have a good sense and we have to talk about this in many diseases. I believe you probably are quite used to what you have to tell patients to minimize their exposure to ticks. In animal settings, that you can use an acaricide, which is a tick killer in farms and livestock areas, and you can make an effort to protect the cattle against ticks. You can quarantine the animals before they enter the slaughterhouse, because that means if they've been in quarantine for 4 weeks before they're slaughtered, they won't have acute CCHF, and this will decrease the risk of animals being viremic at the time of slaughter. But nevertheless, people in slaughtering houses and who butcher animals should be careful about contact by wearing masks and gowns. The human-to-human transmission issue is partly an issue of getting early recognition, and secondarily, when it is recognized in healthcare standards, implementing strict precautions, because we see a fair amount of healthcare worker illness from this. So that's the story on CCHF. I'm going to switch to Mpox and start with the standard wisdom. The standard wisdom is that there were originally 2 strains, one in Central Africa, now called clade 1, and one in West Africa, now called clade 2, and that for many, many years, this was mostly a rodent to human transmission, and there was quite rare human to human transmission. Clade 1 was felt to be more lethal, 5% versus clade 2's 0.2% fatality. This, I think, is exaggerated. We'll see in a second. So that what changed about Mpox is that in 2018, clade 2b arose out of the West African isolates, and it could transmit sexually and did quite aggressively. This is the one that caused the global outbreak of 2022, largely in Europe and North America and South America, but actually quite global. Same thing happened in 2024 with clade 1. Clade 1b arose, and it could transmit sexually, and it's done so with considerable vigor. So clade 1b spread rapidly in Central and West Africa. It is the one that caused a recent outbreak in Uganda. And we have it now in the United States. We've had 3 cases in California, all in men who have sex with men, and none of them were related to each other. This indicates that we have community spread now of the 1b clade. Mpox was originally declared by WHO an international emergency. When the 2b outbreak abated, it was decategorized as an international category, but it's again a WHO international emergency due to the recent 1b spread. So here's what happened globally to 2b. The countries most involved were the US and Brazil, and third was Spain. And it had a rather sharp rise, and then it went away. Now, this issue of where it went or why it went there is really unresolved, in my opinion. We only vaccinated about 10% of the candidates with a Jynneos vaccine, and there was not that much recognized illness. It just went away. I have wondered if somebody ever did a serosurvey of the target population, they would have seen if there was asymptomatic spread. I don't know. That's a hypothesis. But the same things happened in Uganda. Here's the case reports for males and females. This is from about 2 months ago. There actually probably are newer data that I didn't get. But as of 2 months ago, 146 districts in Uganda had been involved. So it's widespread. 120 of these districts had more than a case. And in the 21 days prior to September 25th, there were also 40 districts involved. You had 50 deaths at that point. Almost half of them were in HIV positive people. And there was this curious gender difference that I don't understand either. Of the males who got this disease, 72% were less than 30. Of the females who got this disease, 68% were more than 30. I think the epidemic is undoubtedly abating. We always have worry about there being poor ascertainment at the end of these things. We'll talk about that in just a second. So in Uganda, the case distribution was not what I would have expected. I would have predicted that the most cases would be next to the DRC, but the highest rates of infection in Uganda were in the south and eastern areas. So here's the WHO's global depiction. If we look at the DRC cases, they're in red. This is actually up till about 2 weeks ago. And I think it's clearly decreasing. They put this little bracket up here to warn us about the potential for late ascertainment of recent cases. But I think it's clearly decreasing. And I think it's clearly decreasing in Uganda. The Uganda are the blue cases. And we see that there was plenty of illness in Western Africa as well. These are the Sierra Leone cases. So I'll switch to the clinical now. This is a set of sequential pictures of a person with Mpox. Again, in the US, we see this around portals of entry mostly. I think this is an interesting series of pictures because not only can you see what the lesions evolve, but we can see how the person is evolving. You can see pretty unhappy right here, and he gradually gets happier and happier, and by the time it's over, he's got a smile. At any rate, the lesions start with papules. The papules get bigger, they umbilicate and necrose in the middle. The necrosis process goes on, the big crusts appear, ultimately the crusts start falling off, and when they do fall off, there is unfortunately scarring most of the time where they were. So we do see it in portals of entry. This would be a typical MSM case of the 2B outbreak. Your 1B outbreak is different. These are pictures from DRC early in the outbreak, and you can see that this disease disseminates early. It's not just at the portal of entry. Likewise, a picture of a child's arm here. So this disseminates differently. So severe Mpox is something to worry about. The CDC does a consultation service for people with severe Mpox. These would be the 2B cases. During this interval here, they looked at 57 cases. 47 of them were in HIV positive people, and only 4 of those people were on antiretrovirals. It was more common in Black African and African Americans. People tended to be homeless. There was lots of admission to the ICU. Probably these patients had died. So in this example, this is a gentleman in his 30s who had not been adherent to his antiretrovirals or his tecovirimat. And you can see these lesions can get quite big in immunosuppressed people. Severe Mpox can do a lot of other things. It can the oral lesions can get bad enough to limit PO intake. It can be in pulmonary, including nodules, encephalitis and transverse myelitis can occur. Myocarditis and pericardial disease can occur. Ocular lesions are particularly awful to look at. I'll show you a picture of that. Conjunctivitis, corneal ulcerations, and penile necrosis can occur. So these are ocular lesions. You can see the conjunctivitis is quite severe. And in this individual, there was progression to keratosis, and a corneal ulcer had developed. So what do you tell a patient when they've got this disease? Because usually you can't put them in the hospital. You tell them to stay home. You tell them to avoid public transportation. You tell them to reduce their contact, not only with humans, but with animals, because it can bounce back from animals. You can tell them to cover their lesions in masks when they can't avoid being around people. In the household, you tell them to avoid sharing items. You try to disinfect those items by laundering. And you tell them they have to do this until the crusts have separated and a fresh layer of healthy skin has formed underneath. If they relapse, they start a new 21-day cycle. Now, the vaccine situation is not bad for Mpox. There are several vaccines available. We, and I think you, use the Genios vaccine. It's produced by Bavarian Nordic. It was licensed to the USA for smallpox and Mpox. It is used in people 18 and over by our criteria. So this is a problem for you because you have a fair amount of pediatric disease. These vaccines can be used in the pediatric population, but WHO has said may be used in emergencies for less than 18. So I think that does allow you to use this vaccine in pediatric population. This is the way we use it. We only use it in people 18 and above. We did give sub-Q for a while. That does allow you when you give it intradermally. So typically with sub-Q, but you can use it intradermally. This allows you to get about 5 doses per 1 ml vial as opposed to 1 dose, but we have enough now, so we still go back to the sub-Q. The adverse effects are not substantial, itching and pain. About 10% have systemic after vaccinations. The contraindications are pretty minimal. We don't do the intradermal disease in people with who develop severe keloids or who have atopic dermatitis because it can spread in that condition. We don't use it for pregnant women or lactating women. Controversial whether you should use it in people with advanced HIV. We tend to do it in that population, but it's not clear that that's the right thing. When patients have had COVID, we usually wait a month before we give them the Jynneos vaccine. It can be used post-exposure. Ideally, we try to do that in 4 days. We have actually never done this, but it can be done. It's said to be okay after 14 days. Now, just last week, there was published a paper that's caused there to be concern about the durability of the Jynneos immunity. These people looked at vaccinated patients and patients with natural mpox, and they tested them all at 8 months, and they found that the recipients of vaccine had lost a good deal of their neutralizing antibody, whereas the mpox, oops, I didn't misspelling, sorry there, had not. They did a number of specimens in these patients at 8 months. All those PCR tests were negative, and they have advocated booster vaccination, which has not been advocated in other contexts. Treatment situation much grimmer. We have 4 candidates. These are all expensive and toxic, and we had tecovirimat for a while. It was originally licensed for smallpox. We were able to give it in a early access IND for either mpox or vaccinia. We've never done it for vaccinia, but we've done, I think, about 20 administrations for mpox. It was seen to be highly effective in animal studies, even non-human primates. It had good safety in a large study of healthy humans. It's renally excreted, so we don't give it to people with creatinine clearance of less than 30. And we increase the dose if the patients weigh more than 120 kilograms. It can be given PO or IV. So problem is, doesn't work very well. This is one of 3 trials. This is the PALM trial. It was the first one published. It was almost 600 people, done in the DRC. All the subjects were hospitalized for 14 days, so there's no issue here about incomplete compliance. 1-to-1 placebo versus tecovirimat. The outcomes, again, that it was well tolerated, but it didn't work very well. There was no reduction in the duration of lesions. There was no mortality was the same in both groups. This mortality, I think, gives you a sense that maybe the fatality rate of 5% is excessive. These patients were hospitalized, they had good support. So the mortality is probably higher than this for the average patient. At any rate, there was no difference by site of lesions or time to initiation. There are 2 additional trials now. The STOMP trial in the US produced the same result. There's an ANRS trial called Unity, which we're expecting results, and it's been examined by the DSMB in mid-December, and they did not stop it, so maybe it's not as clear-cut in the Unity trial. At any rate, that's the end of my talk. Appreciate your time. Looking forward to questions if we get a chance.
Okay, thank you very much, Sarah, for the insightful talk and for everybody in the room and online for kicking around. We'll now go to our last presentation and then go into the question and answer session. The last presentation is on the role of data harmonization during the rollout of lenacapavir, and it's going to be presented by none other than Dr. Alex Asinwe, a biopharmaceutical executive and health research leader with extensive experience in evidence generation, innovation, and strategic partnerships across the globe. He's a professor of the field. At Gilead Sciences, he drives initiatives that leverage real-world data, foster collaborations, and develop innovative health solutions to improve patient outcomes. He's committed to advancing access to quality healthcare, strengthening research systems, and promoting data-driven decision-making in the public and private health sector. Welcome, Dr. Singh.
Thanks so much. Okay, thank you. It's an honor to actually be here. My name is Alexis Sidway. I'm based in California, San Francisco. I work for Gilead Sciences. And at Gilead, I'm responsible for all the real-world evidence generation for all the products we have planned for the market. I'm also responsible for all the data governances and company. Okay, disclaimer, of course, you all know I work for a pharmaceutical company, which is a Korean one, but all the views expressed here will be my own. I'm not going to talk on behalf of Gilead. I'm also not going to talk on behalf of policy. You're going to hear more about policy, especially facts of that in my class. So the topic is really all about the role of standardization or harmonization as we try to roll out any new drug. In this case, that's clinical career. To create doesn't matter whether it's clinical career or not, the role of observational studies, so those don't be the same when you're going to roll out any product. It's not just rolling it out, you have to continue to the whole life cycle management of any product or not. So just if I can go any further, just want to clarify a few things. In all the discussion I'm going to talk about, I'll be using the word data. And that data is not applying to real world data. It includes all the clinical trials. So don't mix those two things. Real world data is excluding both clinical trials. And you're going to hear me using the word standardization and harmonization almost in the same way. So it is the same rule that. Okay, so really what are the main gaps when you're trying to roll out any drug? So the main gaps are always going to be utilization of the drug itself. We want to understand the background information of the HIV, for example, because that helps the company to forecast the demand and then produce more product for distribution. But also, most importantly, especially for HIV, persistent rates and pattern use of PrEP is going to be very, very key. And then, of course, you can't do without surveillance and pharmacovigilance activities. Again, for the Caprivian and of course, look at data, we show what they are talking about. We are going to be monitoring the impact of really looking at the HIV incidence rates reduction over a period of time. So it's not just 1 year, we always have to use this data over a long period of time. So which kind of data I've already mentioned is always going to be routinely collected data in the system. Again, it excludes all clinical trials or program activities. That's the one way we can after filing work data. So why is it real world data is more important than clinical trial? Why should you not do a clinical trial? Well, clinical trial can take so long, actually there's a lot of lots to follow up. And really, we always want to generate evidence as soon as possible and fast and quick. Fast, quick, and check. Because we don't want to delay any evidence that may come to in practice. We want to bring that evidence to patients quickly, also for the policymakers. Okay. So remember, we use the word standardization or harmonization. I'm going to change it into a common data model. So what happens is every hospital or every institution collects data differently. Now, if it is different, it is different. So when we're looking at harmonization or standardization, is we are trying to see how can we make sure that if you collect data in one hospital, one institution, and another institution, and you harmonize it so that it becomes the same standard. Really, that's what we are talking about. Now, there have been an attempt to create different common data models, or what we call different standardization models, and most of them are there. Most of them were created for specific reasons. But there's one common data model or commonization that is much more relevant to what we're doing. So that's the one that's called Odyssey. Now, Odyssey, I'm going to tell you a little bit about Odyssey, but that's going to be the focus. Well, the Coronal, Sentinel for the FDA, and a few others. Each one of them has its own advantages and disadvantages, but the main one that we're going to be talking about is Odyssey. Okay, so what is Odyssey? So Odyssey is an open source community which focuses on converting data into a common data model. They actually do also generate a lot of evidence, as I'm going to show you. Just as a snapshot, every dot you see on the map represents the data that's owned by an organization, whether it's a hospital or an academic institution. Okay. There are different collaborators. So far, there are about 5,000 collaborators around, but the data network that has grown has about 500, 600 data sources. These data sources are available to be accessed by any researcher. Right? And why is this one so important? Again, I mentioned the word fast and reliable sources of information. There's reduction of cost. These studies are very cheap if we want to do that. But also there's expanded data access. So I can do a study in all countries that are on that node and get the results within a very short period of time. But that helps me actually do comparisons between countries, between regions, and all that kind of stuff. Okay, so why are we talking of OMO, who actually funded? Didn't come out of blue. It was because of the US government. The FDA was mandated to at least create a network in the US where they should achieve about 100 million patients by 2012. That's a long time ago. So there was then an experiment that was funded by the FDA, and that experiment was called OMO. It lasted a few years. And that's how, when they found out that it was not easy to actually do analysis, particularly in different hospitals in the US, they came up with this common data model. Right? So the funding ran out, and it ran out in 2011. Then Odyssey was formed. Because once funding runs out, most cases things go down. But in this case, it timed differently. People who are interested, they saw the usefulness of OMO, and then they created it called Odyssey. Okay, so that's number one. And then over time, you can see all those time frames. We're going to see that then Odyssey started really converting a lot of data sets across the world. Now, by 2015, you can see countries like the first symposium took place, and then you have countries like Korea now started joining up. But the most important thing that really where people started getting traction was when EMEA, for example, started adopting the use of common data model. Now, let me tell you what actually common data model looks. Then you understand what I'm talking about. So imagine you have a research question, and that research question is really looking at the appearance of a drug in your data sets. So at the moment, maybe you want to be in multiple countries. So that's how it looks. Every country, the data is different, or every institution, the data is different. So if you wanted to do studies in multiple countries, normally what you would do is you have a separate protocol, a separate statistical analysis plan, a separate analytical code for each one of those data sources. That's very expensive, it's not scalable, and it's very slow. You have been involved in getting ethics approvals, you probably know what I'm talking about. And then there are also data governance issues. So the solution is, what if every data base has a similar standard with the same structure? Then you should be able to conduct the study, whether it's a safety, a mortality study, and adherence quickly just by using one protocol. You should only be using one code, And that makes it easy. And I don't want to access your data. I will not ask you to access your data. Because if one script, source code, works on another person's data source, you just send it and then people can run the analysis and give you the results. We are interested in the results, not the data. So that way you're going to get a broader spectrum of results from different countries and that way it's cheaper. And then you're thinking of generalizability because then become an epidemiologist, then that helps actually looking at this one support. Generalizability. Okay, so you are moving away from traditional way of doing things to the new way of doing things. So I'm not saying that everything has to be addressed in a harmonized way, but if you are interested in looking at different regions, different continents, countries, the almost common data model is probably the best approach. You can get the results much faster and cheaper. Okay. Maybe for those who like pictures, this is a kind of a demo of what happens. Imagine you're traveling and you want to assume that the flat iron is your research question. So on the left side, that's your raw data. So which means you're always going to buy an adapter to fit all those adapters. But if you harmonize your data, you only need one adapter. Every time you have a new research question, similar like in any country, the same adapter should work. That way you are simplifying things, really, and making the cost of the studies much cheaper. Okay, in a nutshell, this is technical, but this is how the data always looks like. You have similar tables across all the time. And the most important thing is you speak Swahili, others speak French, others speak German. But the question is, how can you standardize things like this when people are speaking different languages? You don't have to worry about that because there's a team dedicated to really look at conversions of different concepts of things. So far, different medical terms have been created. And imagine 10,000, actually more than 10,000 medical concepts have been created. And those medical concepts can translate to the Swahili, to French, to English, all languages. So you don't have to worry about it. And that's the reason why we are almost created this one. So I think I will give you an example. If you want to filter the data sources and you want to work cheers, you don't have to worry which language to speak. Because cheers, the system will know which language should translate to. So since you're all clinicians, let's say, for example, you want a collaboration and you're using ICD code, it doesn't matter whether you're using a biobank or Nebraska or any other data source. All you need is just to know what the standard concept is, and you should do it all themselves. Okay, so where are we so far? All those things you see on the screen are regulatory bodies. You have the PA, you have NIH, you have Darwin from European Medicine Agency, and then now recently I've started to see Asian countries. All of those institutions have adopted using almost common data model to assess the drug and effectiveness in characterization of diseases. But if you look at the FDA, where they have a lot of money, they are using a central place where you can use to generate evidence quickly, what we call rapid assessment. You don't have to wait for months, you don't have to wait for years to understand the population or how bad this is in the organization across the world. If you are looking at European Medicine Agency, billions of dollars have been spent here. European Medicine Agency have what they call Darwin. Darwin is responsible for conducting all observational studies for European Medicine Agency. And those observational studies are all based on data that has been converted into common data model. And everything can be seen on that map as data on common data model. Now we go to Asia specific, that's what we also see. But that's what we also see. Asia is also going forward quickly with a lot of investment that almost has really taken up. We can talk about almost 60 hospitals, which is equivalent to about 97, 98 million patients are already in common data model. Okay, So you might wonder, are there examples where actual studies based on have played a bigger role? Yes, there are lots of examples, especially when we were doing COVID-19. COVID-19 was really the time when that started playing a bigger role. Okay, so one of the examples was looking at the studies on IRBs and SCEs, and you can see here the was really looking for the answers very, very quickly within a month to get that to us, and that information was available quickly. The very good example is about hydrochloroquine. That was a very good one. Of course, that led to the EMA sending out a note about the side effects and hydrochloroquine and around. There are many other examples. It's not just COVID, because COVID is being about COVID, but you have other things like hypertension. There were studies which were on hypertension. After these studies were interesting, so they wanted to compare Western world and Asia and see really how things work on no combination therapy pathways. So you can see there were about 112 million patients which were studied, and in the end, the key results here was that patients in the West were different from patients in the East, West being European and the East being Asian. And this would not have been easier to do if, for example, the form that model was. Okay. You don't have slides. All these are examples where that model was used and how it has impacted regulatory environment and policy making across the globe. Okay. So what are the key takeaways? The key takeaways is standardization is available, it's actually free. If you know you have data, you are it's actually can come the products of computers, they will convert the common data model and become part of the other node. So at the beginning of the presentation, that way it's going to help us generate real world evidence related to the behavior, the way to demonstrate incidence rates have gone down and errors have, is okay. That way we need this approach. Now, standardization, of course, exists. It has taken us so long to reach this point, but we have finally reached there because you can see regulators have now adopted use of common data model. Again, remember at the beginning of my presentation, I said there are other common data models, right? But this one seems to be the one that has had traction over time. But it's because of the investment that have gone through it and people's willingness to actually try it going forward. If you are interested in multi-site, multi-country, or multi-organization kind of studies, observational studies, you should be able to exploit the power of OMO to generate the evidence quickly, faster, cheaper, and generalizable across the board. I think with this, that should be my end of my slide. We have access to the slide. There's so much information in the slides. I will show the best.
Very much. Interesting way, the insightful perspectives of data. And in this data, it's very, very key for the field of the make, both for project management, but also for research, all the other aspects of the we'll come to the end of our session, and we had a few questions in the chat. We will answer one, which is put from one of our members from Ministry of Health. We do have one from Dr. Salim to Dr. Ram. Does prior smallpox translate for the dividend for the need of pimples and disease contribute to lower disease manifestation with older folk? What could explain the age disparity across the males and females in Uganda? Dr. Ram, are you there?
He's still there. Right.
Yes.
He's there.
He is muted, so.
So are you, I'm sorry, are you talking to me, Frank Rain?
Yes.
So ask me the question again. Sorry.
Oh, okay, because a doctor, I mean, a question from Dr. Sadi, and he said that does prior smallpox vaccination eliminates the need for mpox, and did this contribute to a lower disease manifestation in older folks? What could explain the age disparity across the males and females in Uganda?
So that's a great question. I looked for some hypothesis as to what that answer might be. If Dr. Sally doesn't know that, then I don't know it. The first person I would ask for an explanation would be him.
All right.
I'd love to hear his thoughts on it.
Okay. Dr. Apes, we will try your questions, but Dr. Eno is not. What?
No.
For the call, so we'll forward those to him and provide the answers when he has responded. Then there's one from Andrew. One for Dr. Asime on the OAB620. I'll ask him to have a look at the question and respond to it.
Yeah, thanks, Andrew. Thanks for you being here, Dr. By the way, is an expert in Oman. Yeah, so I think Andrew is asking for, if you want more information, maybe you can ask. I think he has listed some tools that can be used in institutions. Again, I just have to repeat this that if you have data, that's the best. I think that's where we are going forward. Converting to the human data model. Run away from just waiting for institutional analysis to actual malconstitution analysis. That's the best way. But since Andrew's here, you can also reach out to this knowledge about the form of analysis.
Great. Thank you very much, Dr. Sime. Then Dr. Elion, glad you're back from the call. One of the questions is, can two-drug regimen be relied on as a switch option for patients failing, for clients, failing clients who are DTG naive? That makes sense. Did you hear that?
I think the question is, do two-drug regimens, are they safe for patients who are failing their first regimen? Is that correct?
Yes.
I'd say they're somewhat safe, but not certain. And it depends on the mutation. If the mutation would be an M184V, then sometimes two-drug regimens can be pretty good. It also depends on which two-drug regimen. If you're talking about DTG3TC in the presence of an M184V, it's not as good, but it's still decent. If you're talking about doravirine islatravir, that would be unaffected, so that would be fine. So to some degree, it depends on the extent that you have the mutations, and in general, you wouldn't normally want to use a two-drug regimen if you had a prior mutation that you knew of, if it was potentially resistant to that new two-drug regimen.
All right, thank you. Then the next one, if DTG is proving superior to boosted PIs, what does this mean to our switch options for clients who fail on DTG? Or what does this mean to having DTG as first line?
Well, I think that the superiority of integrases in the case of Uganda, the use of DTG, because that's what's available, is a striking development. And I think it makes sense to always think of the integrases as a regimen instead of proteases to begin with, unless someone was on an integrase for PrEP. Then the question becomes, how does the role of an integrase play in second line regimens? And studies have shown that integrase regimens do very well and sometimes outperform proteases even in second line regimens because there's not a presence of resistance. So I think that has to be made in individual cases to look at what other drugs you can combine with DTG in a second line regimen And for the most part, because of the greater tolerability, it's going to be more effective than a PI-based regimen. It doesn't mean that PIs don't have value. It's just that integrases often retain their value.
All right, thank you very much. Anyone in the house who has a question?
Yeah, thank you, Chair. And this one goes to Dr. Sisson. Thank you so much for your presentation on the example ART. And you mentioned that some of your patients actually have asked to whether we can access the injectable ART. JCRC, and your answer was no. Now, what if someone asked where they access it from, from an open market? They have their money. But I guess that you're telling them not to come because it's not available. It hasn't been confirmed and without a national platform. But if it's private, someone can actually afford this. What would be worse?
Thank you, William. So the answer is not no. The answer is not yet. And currently in Uganda, you cannot get these drugs for treatment except through research because they have to be registered in the country by the National Drug Authority. They are registered, at least cabotegravir for PrEP, and lenacapavir is going to be registered also for PrEP. So I think we should work with the regulatory authorities to register the drugs in the country outside of research, but how do we actually access them? In the past, we worked with our collaborator, Case Western Reserve University, to get antiretroviral drugs here as they became available on the US and European market. So today, in this room, there is Alex, there is Sahara. You need to have, and there are also US colleagues on the call. How can we get these drugs for those that are able to pay for them into the pharmacy so that they are here in Uganda? In the past, people used to travel abroad to get these drugs, and people may still travel even for these injectables. Then we brought them here in the country, and then what has happened since then is history. But I think they are still very expensive. They are still very expensive. We expect that generics are going to become available. So watch the space. We are also working with all our networks to see what we can do. But I think generics is what would be feasible for patients, even if they can pay out of pocket. And then before we get this into national programs, because that also takes time. Yeah.
Thank you very much. That is not fantastic. We'll have one last one to Richard from Dr. Akwari. The weight gain debate with these stills and tough is controversial. Any comments?
Could you repeat the question? I didn't quite understand.
The weight gain debate with integrase inhibitors and tough is controversial. Any comments?
I have a lot of comments about that. We did a study that we presented at IAS. It wasn't at CROI, so I didn't cover it. But in the study, we looked at close to 15,000 men and women who were HIV positive and 15,000 men who were HIV negative. And we then matched them for various diseases and comorbidities, and we followed them for 2 to 3 years. The amount of weight that each population gained, the HIV positive and the negatives, was similar. So in fact, people gained weight, and the HIV population didn't gain weight at a higher rate than the HIV negatives. However, we did notice that there was an increased rate of people who gained more than 10% of their weight. And so we then did a further analysis to look at those who gained 10% and those who gained 5 to 10% to compare to see if there were significant factors we could identify, specifically ART agents. So we were able to focus our investigation on the subpopulation of people who gained the most weight. When we did that study, the main factors that determined weight gain were demographic factors, not the choice of ART agents. So it had more to do with gender, it had more to do with race, it had to do with other factors that were not related to ART regimen. So it's my opinion that in general, The impact of ART agents is very complex on weight because some affect hunger one way, some affect another. But overall, the weight gain that we see with HIV positive is not really due to the specific agents. It's more due to what happens to the global life and lifestyle of that person who's on the regimen. And I know that's controversial because of the studies that were done in Africa. And we tried to be very careful about the way we did those analysis, but that's my current thinking.
Great, thank you very much. Please join me for applaud all the presenters. We'll break the 20 minutes for the time and go on to the breakout session. Go back to the secretary. Thank you.
The next session are going to be breakaway rooms. We are going to launch them, then you're going to choose which room you want to go to.
So select going on your device. Join on your device. Able to transition. We will allow some time. Need help. We have items that are ready to help you. Allow us to do that.
Please select and join any room. Join in a room of your choice, please. Select and join in a room of your choice that you want.
On a computer, you do, but you can share them. You'll share them and I'll just go to advanced. Perfect, because my computer is.
Them join another.
Members, please join the different room, the breakaway room. Hello, members. Kindly join different rooms, the breakaway session rooms. Members, kindly join the breakaway session room. We have 3.
I have failed to join. I don't know how do I join?
On your screen, you should be able to see the different rooms, the different 3 breakaway session rooms. You can choose one. Are you able to see it, Alicia? Members, we still have the 3 breakaway rooms. Kindly on your screen, you should be able to have that pop up. Kindly join on any of the 3. Thank you. Hello, Alex. Riazael. Are you able to join the breakout session, any of the three? Are you having any challenges?
Don't have any challenge. I'm hearing you well.
Oh, okay. No, we have three breakout sessions. You can join on any of the three.
Okay.
Tap on the icon down, the three, there is a sign of more. You'll be able to see where there is breakaway sessions or breakaway rooms. Yes, Mr. Bonne, thank you for joining in. We have three breakaway rooms. You can join on any of the three. Good evening, Bonnie.
Yes, Frank, good evening.
Good evening to you. We have three breakaway rooms. You can join on any of them. At the bottom of your screen, you should be able to see the breakout rooms. You can join on one that you prefer.
Okay, thank you.
You're welcome. Hello, Stella. Good evening. Thank you for joining. We have free breakaway room. You can tap on the icon and you'll be able to join on any of the three. tukutana shida sopande kie tamanyu yeturi mukati. Breakaway session. Mhm. Ila vudem breakaway say.